Hello again, students. It's chapter 10 in Jarvis, and chapter 10 deals with vital signs. So we're going to describe various routes of temperature measurement and what special procedures would we consider with different routes. We're going to look at four qualities considered when we assess the pulse, describe the relationship between the term blood pressure, systolic pressure, diastolic pressure, pulse pressure, and mean arterial pressure, and then list the factors that affect blood pressure and also relate the use of a blood pressure cuff of improper size to possible findings that may be obtained. Okay, so vital signs, when we are taking vital signs, generally, again, a CNA may be the person that would have taken the vital signs, but sometimes there are nurses that have no CNAs working with them, and so they're responsible for their own vital signs. So vital signs would include temperature, pulse, respirations, O2 saturation in some instances, and the person's blood pressure value. So when we are doing the temperature, depending on your facility and the equipment, you may either take a temperature in Fahrenheit or Celsius, either or. And depending on which one you take, you may have to do the conversion. And sometimes it's as simple as pressing a button on the equipment and it'll quickly convert the temperature to you or for you. So normally our body maintains a regular temperature, except sometimes our temperature follows the diurnal cycle, which would be that it's lower in the morning and higher again in the afternoon. Sometimes you can see temperature changes in women when women are ovulating. Sometimes the temperature also goes a little bit higher as well. So temperature control, we know, is regulated by the hypothalamus in the brain. Normally, where our temperature lies is 98.6 Fahrenheit. Generally is what we say is normal, or 37 Celsius. So anywhere from 96.4 Fahrenheit to 99.1 is considered normal. And then a rectal temperature we know is usually a little bit higher, which is about 0.7 to 1 degrees Fahrenheit higher in a normal adult person. So in this day and age with COVID virus, you may have heard them saying that patients have one of those symptoms that they have is a fever. And then patients will be going through chills and shivering with a higher temperature. So when we assess a temperature, it could give us some valuable information on what is going on with patients. Exercise is one of those other things that can actually affect the patient's temperature as well. If you're out there and you're running, right, and your body is actually doing some heavy duty work, then the body temperature is going to increase. And so we generally give that a term hyperthermia, but we generally use the term hyperthermia when we're actually talking about a problem like a fever that's caused by something like a bacteria, etc. There are some other disorders like stroke or maybe cerebral edema, tumor, maybe the patient has surgery that can actually cause a patient's temperature to be elevated. So you will see those temperature changes as well. In older adults, generally the temperature is lower than what the normal adult is, and especially age-related changes that occur to the older adult. So sometimes they may not be able to mount a significant response to, say, a bacteria or a virus that is, rampaging through their bodies, and so that person may not be able to have an elevated temperature. Like sometimes when our older patients have a urinary tract infection, we may not see a temperature change as we're expecting. Like a younger person sometimes may have a higher temperature. So we have to keep those in mind as well. So rectal temperature, why would we take a rectal temperature? Well, if we can get the temperature by no other means, then we go to a more invasive temperature. Or maybe a patient is comatose. With a comatose patient, you may want to truly get what their core temperature is. Maybe a patient has had trauma to the face. You can't really put a thermometer in the patient's mouth. So you are then going to utilize a different method of taking a patient's temperature. Okay. Whenever you're going to be exposed to any kind of body fluids, you definitely want to be sure that you're wearing gloves when you are assessing these temperature or these measurements. Now, back in the day, we used to use a glass thermometer. There are a few of them around, but you may not see them readily available as well. So it's quite easy for us now to take a temperature on a patient. For the most part, these days, we're doing tympanic temperature that we're checking on patients, or the more actually temporal artery temperature you may have seen as well, where they slide the machine, the thermometer really across the forehead and sometimes around the ear, along the ear, and then the temperature comes in. You put a thermometer right inside the external ear canal, and you can get a temperature that way. So there are different ways of actually checking a patient's temperature. Now, when we assess a pulse on a patient, we look for a few things when we assess the pulse. Now, when I was just learning how to take a pulse on a patient, generally they tell you, we were told that you check a pulse by counting for about 15 seconds and then you multiply that by 4. But research has been done and shown that actually that is not correct, because if we miss a beat, then remember we multiply by 4. So if you miss one beat, that's like 4 beats already missed. And think about sometimes where maybe the pulse was faint and we didn't pick up more than one beat. So now we would have missed a lot of beats in our patient. So we no longer use the 15-second interval, okay? We go for 30 seconds when we're checking a pulse. If it's regular, if the rhythm is regular, we go for 30 seconds and then multiply by 2. At any point, if the patient's pulse is irregular, we are going to count for the whole minute. Now, when we start to count, how do we count? Do we start with the first beat as 1, 2, 3? Actually, we want to start with the first beat as 0. So when you feel that first pulsation, that first beat, that would be the start. So you count with 0, 1, 2, 3, and then continue onward. Again, anytime their pulse is irregular, then we are going to count for a whole minute. So we look at the rate, which is the number that we're getting. We look at the rhythm, whether it's regular or irregular. And then we also look at the force. How strong is that beat that you're actually feeling? Normally we have about 70 milliliters of blood that we are pumping in the body. And so every time that heart pumps or contracts, that blood is pushed forward and we feel it in those specific pulse sites around the body. Okay. So again, start the count at 0. And if it's irregular, you're going to count for a full minute for the pulse. Now, when we count for a full minute, what are we getting? So let's take a look at the rate. I remember when we were in nursing school, we know that normal rate is 60 to 100. That's what most of us still use even these days. But research actually came out, and the findings are that the normal resting range for adults is actually 50 to 95. I have not seen many places that have converted and they're using that specific number. You still hear individuals using the 60 to 100. However, depending on where you are, just be aware that sometimes normal would be considered anything greater than 50 and through 95. Anything greater than 95 would be then abnormal. Okay? Rates generally vary with age. When we look at a pulse, say, of an infant, we find that the pulse is much faster than the adult. And as we age a little bit, or as we continue to age, then the pulse actually drops and becomes a little bit less. Females are a little bit higher also as male. Now, if the pulse, when we check the pulse, is 50, okay, so we're going to use the 50 mark, then we consider that as bradycardia. Okay, so it is slower or lower. So we consider that bradycardic. Again, 60 to 100 or 50 to 95 is what would be normal. So if I have a pulse that is, say, 49, then I'm going to consider that bradycardic. Okay. If the heart rate is, say, greater than 100 or maybe 95, if you're using the whole old new value, then we consider that it is now tachycardic. Okay, so tachycardia or tachycardic is the word that we actually use when it is faster. Now, there are many different reasons why a patient would be tachycardic or have tachycardia. And some of those reasons we will pick up as we move forward. Um, if I just exercise, like I said recently, I've been out there running, then my heart rate is going to be much higher. Does that mean that I have a tachycardic problem? Not really, because I was doing something specific that caused that to increase. But if I was laying in bed resting, and when my pulse is checked, they find that my heart rate is, say, 110, then I know that there is a problem because my resting heart rate should not be over 100. So I would have a particular problem. They would try to assess what is going on with me. Okay, so bradycardia is less than 50. Tachycardia is anything that is greater than 100. Again, COVID-19 is around, so what you may find for those patients who complain that they're having a fever, right, temperature, then they probably would have something like bradycardia occurring. You may also hear in the news that some patients go to the hospital with pneumonia. That could also cause the patient to have tachycardia. Okay. Uh, Again, bradycardia could not only be caused by someone who, say, an athlete who runs a marathon, a marathoner. A marathoner would have a very low heart rate because their heart is well um, developed. It's very efficient in actually pumping those 70 milliliters of blood around, but doing it with less beats. Okay, so they would have a heart rate that is maybe 50 or could be even less without them having some kind of potential problem. Okay, there are other patients whose heart rate is bradycardic for specific reasons. Maybe we've given the patients medications that could cause the heart rate to be lowered. Okay, so maybe I've given patients a medication to control high blood pressure. Then I check the patient's heart rate, and the patient's heart rate is, say, less than 50. So it would be bradycardia. Okay. So it all depends on what is going on with that specific patient when you check their pulse and see where their heart is. We can't just take the value, the number that we have by face value. We have to know what is going on with our patients. Now let's look at the rhythm. So I said that the rhythm could either be regular or irregular. Okay. Normally when our heart beats, it beats a rhythm. So it's beating regular, and then sometimes it picks up and it goes much faster, or it would go slower. Sometimes it would be an interrupted. So it would beat, 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 then it go beat, 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 right? So that could be irregular. Now, sometimes when we breathe, we take a breath in and out, it speeds up the heart rate a little bit, okay? So that is normal, that our heart rate is going to speed up with when we are breathing. So it speed up when we take a deep breath in, and then it slows down when we expire. That is quite normal. Okay? But a person that has, say, heart disease, sometimes have heart rate that speeds up, slows down, speeds up, slows down, and it's a little bit different, like someone that have atrial fibrillation. So again, we have to know what is going on specifically with our patient. Children and young adults sometimes have what's called sinus arrhythmia, and it's generally just an irregularity that occurs in younger patients. Okay. Um, let's move to the next slide. Okay. So the force of that pulse that we're looking at, we can determine and measure it by giving it a 0 count for no pulse at all, it's absent, 1 plus for a very weak pulse, 2 plus is what we consider normal. If you are sitting listening to this lecture, hopefully you have not been doing anything like maybe exercising, running, and hopefully you don't have a fever. But if you feel your pulse, try to feel your pulse at your wrist. Okay, so take your index and your second finger, press down very gently over your pulse by your wrist on the thumb side of your wrist. So press hard and then relax your pressure just a bit. You should be feeling a bounding going on. So normally we'd give that bounding a 2 plus. Now if you got up, like I would normally do with my students in class with this lecture, and then have us jog for about 45 seconds to a minute, right? So we're jogging around, and moving like you are indeed jogging, and then you're going to stop. So now you're going to feel your pulse again. So now when you feel your pulse, that force is a little bit different. It's stronger, it's more full. That would be a bounding plus, so we give that a 3 plus. So we can measure pulse by either giving the force of anywhere from 0 to a 3 plus. Okay, so if I exercise or if I'm really anxious, my heart is going to pump a little bit faster. Think about if you're walking and all of a sudden you look behind you and you hear a dog coming behind you, ruff, 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 right? And all of a sudden you became very anxious and your heart started pounding. If you checked your pulse, that would probably be a 3 plus. Okay. For a patient, I don't know if you have ever had patients that's going through the dying process, or maybe a patient that has had trauma, multiple trauma, lost some blood, and you are checking and you're feeling their pulse. You could sometimes hardly feel a pulse. It's there, but it's very weak. We'll give that pulse a 1 plus. And of course, someone who's died, if you press their pulse, right, you're in a cold situation, you hear, no beat, telemetry monitor is saying it's 0, you press that patient's pulse site and you actually don't feel anything. So that pulse would be an absent pulse. Okay. So there are different reasons why we would have different force to the patient, but just remember 0 to a 3 plus is how we actually force. Now, respirations on a person, normally when someone is breathing, you don't really hear them breathing. Although there are some individuals that actually have a loud kind of respirations. They breathe heavy, and there is absolutely nothing wrong with the patient. That's just normally how they breathe. So when we are generally breathing, it's regular. We don't even think about our breathing. It's automatic. If you've ever had that child that says, I'm going to hold my breath until I'm blue, right? Then we shouldn't really struggle about it. Just say, go ahead. Just let them hold their breath. Because after a while, the body's going to compensate for that. And they're going to start breathing on their own, right? So it's something that we don't think about. It occurs normally. Okay. So when we are assessing a person's respiration, so if we tell a person that, okay, so now I'm going to check your respirations, what happens? You're absolutely correct. They're going to start thinking about how they're breathing and they're going to try to breathe. But when that happens, now their breathing is completely off. So what you want to do is you just tell your patients normally that, you're going to check their vital signs. They're going to, check their respiratory rate. My goodness, it was difficult to say. So you're going to check respirations. You're going to check their respiratory rate. You're going to check blood pressure. And as you are manipulating and checking the person's pulse, just keep your hand in place after you finish counting their pulse. And now you're just watching their chest rise and fall. So you're checking their respirations without them even knowing it, right? That way they can't influence what the respirations is. And of course, when you are checking respiration, you're going to have the person inspire and expire, and that would be counted as one. So make sure inspire, expire, that would be one. So we count for 30 seconds. If you feel that or note that it is irregular, then of course you are going to do so for a whole minute. At some point in time, if you want to click on the YouTube link that is there, you'll see a person actually completing pursed lip breathing. Sometimes when we get a little bit anxious, sometimes patients with asthma, when their respirations are really fast, person gets a little bit tachypnic, we have them do pursed lip breathing. Okay, so you take a breath in, purse your lips like you're going to be kissing, and then blow the air out. You hold that for a count of 4 beats, and then the same thing, you inspire for a count of 4 beats. Sometimes when we are taking exams as students, we are sometimes overcome with anxiety, and your heart is just beating so fast, and you start breathing really fast. Then you need to be able to slow that down so that oxygen can actually get to your brain and you can think about what the question is asking so you can put the right answer down. So you sometimes can do pursed lip breathing while you're in the midst of your anxiety to bring yourself back down, right? Calm yourself. So take a look at that video. We can teach our patients how to do pursed lip breathing to help reduce some of the anxiety level and to get their respiratory rate back to what quote unquote normal is. Now for our blood pressure. When we assess our patient's blood pressure, we look for 2 things. We need to assess what the systolic blood pressure is. We also need to assess what the diastolic blood pressure is. So the blood pressure generally is that force that we feel when that heart is pumping, the blood is pumping against the walls of the vessels. So that's the force that we're feeling. And the maximum force is what our systolic pressure is. And then the diastolic force generally is that resting pressure that we have within that vessel. You may also hear about mean arterial pressure or MAP. Normally for us novice or for a novice nurse, it's not something that you are actively dealing with. For students, say, or senior students maybe, or med-surg students who are going into maybe the ICU unit, you may see them, not may see them, you actually will see them refer to the MAP all the time when they're assessing the patient and administering medication to the patient. They will mention the word MAP, mean arterial pressure. Now, generally, to get MAP would be two times the diastolic blood pressure plus systolic blood pressure. Divide that by 3, and you get the value of what mean arterial pressure is. Or you can say mean arterial pressure is the diastolic pressure plus 1/3 pulse pressure. And then, so what is pulse pressure? What does that mean? That term was named and it confuses a lot of students all the time simply because it's called pulse pressure. Now, if I hear the term pulse, what am I going to be thinking? I just told you a moment ago about checking your pulse, right? So you're just going to be thinking that's what you get when the heart contracts and the force that you feel. But actually, this is not what pulse pressure is in this instance. So they should have named it something completely different. However, pulse pressure is the difference between systolic and diastolic blood pressure. So pulse pressure, the difference between systolic, so the highest blood pressure, and then diastolic, the lowest blood pressure. So an example would be a patient that has a blood pressure of 120/80. So systolic pressure is 120, diastolic is 80. So you subtract 80 from 120, and then the patient's pulse pressure would then be 40. Okay, so that's how we get a patient's pulse pressure. Now, blood pressure for different individuals can be a little bit different. We know that African Americans have a higher blood pressure than our Caucasian counterparts or a Hispanic or non-white person. And the incidence of hypertension is um, it's twice as high, of course, but sometimes we're not quite sure exactly the reason for hypertension. It could very well be related to the environment. It could very well be related to the individuals not having insurance. So, could it be related to diet? Could it be related to stress? A variety of factors that actually can cause hypertension. But for the most part, we know that African Americans have a higher blood pressure value than our Caucasian counterparts. Now, what affects blood pressure? There are a few things that actually affects a patient's blood pressure. Cardiac output affects a patient's blood pressure. Now, what is cardiac output? Generally, it's the amount of blood that is pumped out every time the heart beats. Okay? So if the heart pumps more blood, then cardiac output would be greater. If the heart pumps less blood, then cardiac output would not be as much. Okay? So the factors that affect would be cardiac output. So the higher the output, higher the blood pressure is going to be. The lower the output, the lower the blood pressure is going to be. So think about a patient maybe that has a lot of volume. So maybe CHF patient have a lot more volume on board, right? So they're going to pump a little bit more blood. So their cardiac output would be a little bit higher because there's more volume in their body. So cardiac output. So then I could say that volume also affects the patient's blood pressure. So the more blood we have in the vessel is the higher my pressure is going to be. The less blood or volume I have is the lower my pressure is going to be, if that makes sense, right? So higher volume, higher pressure, lower volume, lower pressure. Think about a water hose when you're turning the water pressure on, right? So the heart is the pipe, the hose is our arteries. And so we turn on the vessel, turn on the pipe, right? The heart starts beating, and you have a lot of water. So open up that faucet, a lot. What comes out? A lot of water comes out the hose. If you turn that faucet off or turn it down so we don't have as much, so lower volume, you're going to have, or it's not as much, so you're going to have a small amount of volume coming, trickling through the hose, right? And then viscosity or thickness of the blood also can influence blood pressure as well. So if it's more viscous, and how would blood become more viscous? What do you think? How about if it's lost, the blood has lost the water in it? Think about a patient who is dehydrated. So now all they're left with pretty much is the solute in their blood, right? So it's now thicker. So if it's thicker, then the blood pressure is going to be higher. So viscosity, the thickness, will actually increase the pressure of the blood. Because guess what? The heart is now forced to push this thicker sort of sludge through, right? Think about a straw that you have and you're maybe taking something up, sucking something up in a straw. How about if you are just drinking regular juice or soda in a straw and you suck it up? Did you get the volume or your soda quickly? Now think about a smoothie that is thicker, right? Ice cream smoothie, it's really thick. And now you are sucking it through the straw. Did it come as quickly? No. And did you have to pull a little bit more, suck in force? Absolutely. So it's the same thing with the heart. If the blood is thicker, the heart needs to pump a little bit harder in order to get that thicker blood through the vessel. So the blood pressure then is going to be a little bit higher. And then the elasticity of the vessel. If my vessels are able to expand easily, then it'll be easy for me to blow through or to push something through it. Then if it's my vessels don't react as much and they have some resistance to it, so it's not as elastic, it's very stiff, then it'll be a greater force for me to get that volume through it, right? So have you ever tried blowing air into an old balloon? If you blow air into an old balloon, it'll be a little bit harder, right, to blow than a new balloon, easier balloon. It'll be easier to blow air into, right? And then the peripheral vascular resistance is also another example of what can influence blood pressure. So I generally give the example of maybe a person that loves to eat meat and potatoes kind of food for most of their life. And then what happens? That increased cholesterol that is in the vessel actually starts building inside the vessel, right? So instead of having a nice open lumen, you now have a lumen that is closed off somewhat. And we're trying to get the volume through it. So think about those vessels in your feet, right? The lower extremity. So we have the blood that's trying to get from the heart to the lower extremities. But down in the legs, the lower extremities, those vessels are somewhat occluded because of all that cholesterol that's built up. So how much pressure is it going to take for the heart to pump blood to get it all the way down to the lower extremity with all that cholesterol buildup in those vessels? Is it going to be an easier time where it could just pump blood, it goes all the way through, or does it have to beat with a little bit more force, pushing force in order to get that blood through? Yeah, the force is going to be a little bit harder, right? So peripheral vascular resistance, the cholesterol buildup, is the resistance that is causing the blood from getting through to the lower extremity rather easy. So if I have peripheral vascular resistance, then it's going to be harder. My blood pressure is going to be higher because of that force. Now, on the other hand, if I have vasodilation, my vessel is able to open up nice and wide, vasodilation, then is it going to be easier to get the blood through or harder? It's going to be easier. So not as much resistance is there, so it's going to be easier. Think about a person's respiratory system. We know that maybe an asthmatic, what happens is you have bronchoconstriction, right? So those muscles are tight and they're trying to breathe air in. It's going to be harder and more difficult for them to get air in. But when you give them medication like bronchodilators, when we give them those medication, it will relax the smooth muscle. The pressure is taken off. Now that tightness is gone from around those vessels. When the person breathes, it's now easier to get that air in, right? So peripheral vascular resistance causes the pressure to be higher, and maybe vasodilation much easier. And this is a good example in your book. Actually, you have this picture on page 145, that if you are a visual learner, the information is just right there for you. So everything that I spoke about last slide is on this slide, which is a great slide that talks about the factors. And you can see that, the factors increase the blood pressure or actually lower the blood pressure. So again, cardiac output, looking at cardiac output, if we have less blood, like maybe the person had an MI where the blood is not pumping as much, so our blood pressure, of course, is going to be lower. So great slide. Now, when we are checking the person's blood pressure, there are a few things that actually comes into play. We're going to use a blood pressure cuff to check our blood pressure. And the size of the cuff is important. If we utilize a small cuff and a larger arm, then we're not going to get appropriate blood pressure. That blood pressure is going to be higher, okay? So we need to have an appropriate cuff. The bladder, which is the part that holds the air inside our blood pressure cuff, that should be about 40% of the circumference of the arm. Our current blood pressure cuff, or the ones that you get in your nursing bags, actually have lines on it that gives you the size. And when you put the blood pressure around the person's arm, those two arrows should fall, or it should close off somewhere in between those two arrows. If it's outside the arrow, then we know that that blood pressure cuff is too small for that patient. If it's way inside the arrow, then we know that that blood pressure cuff is too large for that arm, okay? And then we're going to need our stethoscope as well. So normally, the bell of the stethoscope picks up blood pressure, but we can also use the diaphragm of the stethoscope as well. So for those patients who are students who are novice, not quite experienced with checking blood pressure, you can actually utilize the diaphragm. It gives you a wider berth, but the bell of the stethoscope picks it up as well. Remember that you don't want your stethoscope to touch your blood pressure cuff at all. So you want to be sure when you feel that pulse height that you're going to actually go about an inch or so, place that blood pressure cuff about an inch or so above that site. And then when you're listening to blood pressure, the important values that we're going to get, we're going to listen for that first sound, which would be our systolic blood pressure, and then we're also going to listen for that last sound. That would be the diastolic blood pressure. Another important piece is that when you place a blood pressure cuff on a patient, you don't want to put it over clothing. You want to be sure it's on the patient's exposed arm, okay? And then you don't want to push your stethoscope underneath the blood pressure because that would change the value. You want to make sure it does not touch the cuff, the pressure at all. Now, when we assess blood pressure, we're going to do the two-step method for assessing a patient's blood pressure. Now, speaking of the sounds you hear, again, the first sound is systolic, the last sound is the diastolic. There are other sounds that you'll hear in between that. You may hear the sounds after you hear the first sound, then the other sounds will become higher and higher and higher, and then it will go lower, lower, lower. So we call these Korotkoff sounds, and Korotkoff generally is the person that first, term the coin for the blood pressure measurement. And then the last sound is what the most important sound that we need as well, which would give us a diastolic blood pressure. So sometimes we may miss these sounds that are in between. So when we check blood pressure, you're going to hear us say that we go 30 millimeters of mercury above that, either what we felt when we do a palpable blood pressure. And that's so that we don't miss what's called the oscillatory gap. That means that an area where it's silent and we don't hear anything. We could mistakenly think, okay, that's it. There are no more beats coming, but actually there would be. So we want to go 30 above that number in order to or to completely miss the oscillatory gap. So it does not affect our blood pressure sound. So in generally going through the two-step method, how do we take this blood pressure? So we want to make sure that when we take a person's blood pressure that they're in a position where the arm is going to be about heart level. So most patients are either sitting up, and then you can rest your arm on a pillow, a table, but someplace that's at heart level. You want to be sure that the person doesn't cross their ankles either, because that could give an elevated blood pressure. And then we're first going to put the cuff around the person's arm. Make sure we feel for the pulse first, because that's how we're going to know where to exactly put the cuff. It's going to be about an inch or so above that site. And then we're going to inflate the cuff while we're feeling for that pulse. We're going to inflate the cuff slowly until you stop feeling it. When you stop feeling that pulse, you're going to go 30 above that number. And that's going to give us a sense as to where the person's blood pressure is relatively going to be, just so we don't miss that oscillatory gap. And then you're going to slowly deflate about 2 millimeters of mercury. When you slowly deflate, then you eventually will start feeling a beat again. Where you feel the beat is what we call the palpable systolic blood pressure. And then you're going to continue to release it until you don't feel it anymore. So at one point you'll feel it, then you stop feeling it. Where you stop feeling it, that would be the palpable diastolic pressure. Okay. Now once you've inflated the cuff and deflated it, you want to wait for about 15 to 30 seconds so the blood can be regulated again. Now this time you're going to put your stethoscope in place of your finger, and you're going to inflate. When you listen, okay, after you've inflated, You're going to slowly deflate and you're listening. When you're listening, you listen and you're going to go to that 30 above number, right? Remember the 30 above number where you got to? Yeah, get to that 30 above number, then you deflate. Slowly, you're going to listen to that first sound. That first sound will be your systolic blood pressure. Keep listening. You'll hear all kinds of high sounds, and then it's going to get lower, 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 lower. When you hear that last sound, note where you see that last sound. That'll be your diastolic blood pressure. And then, excuse me, continue to listen until you don't hear it anymore, about 20 to 30 millimeters of mercury. Excuse me. And then report what your pressure is. So now that we know how to take our patient's blood pressure, we're going to sometimes take orthostatic or postural vital signs. So orthostatic vital signs. Your physician would generally ask for this. Now what they're asking for is they're asking for vital signs when the patient is in different positions. So we can take blood pressure with the patient maybe supine, lying down, flat, when they're sitting up, and also when they're standing. Their physician is looking for a change in blood pressure value or heart rate. And the change generally occurs, we say they're orthostatic, if there's a change of maybe 20 millimeters of mercury or greater, drop in the person's blood pressure, or maybe an increase of 20 beats per minute in the person's pulse. Now, a normal person, when we change position, we have about, 10 beat or 10 millimeter drop, but it's not significant. But a person who is has orthostatic hypertension sometimes complain that when they change position, they feel a little bit dizzy or woozy, right? Those individuals we have to be sure to teach to stay in one position. Once you change it, stay there for a moment. Let your blood pressure regulate before you move. Otherwise, they're going to fall, could potentially fall and injure themselves. So this would be orthostatic blood pressure or vital signs. We want to be sure that we allow the person to relax first, right? And then we take their blood pressure. Let's just say that they were outside walking. We allow them to relax for a few minutes, then we take the blood pressure. Within a minute of them changing position from maybe going laying down to sitting up, we have to take the blood pressure sitting up, the value then. And then within a minute of them standing, we need to also take the value at that particular time. Okay, so that would give us orthostatic vital signs. We can sometimes take a thigh pressure. Why would we take a thigh pressure? Well, sometimes we have patients that have arms that are so large we cannot fit a blood pressure cuff around the arm. In this instance, we could use the forearm. But what if that patient, say, have a PICC line in that arm? We cannot utilize that arm. Or they've had a mastectomy on that left side and removal of lymph nodes, so we cannot use that arm. But we can sometimes use the thigh. So we get a thigh blood pressure cuff and utilize a thigh blood pressure. Normally, the pressure in the thigh is greater, is higher than the pressure in the arm itself. So anywhere from 10 to 40 millimeters of mercury higher. On occasion, a patient may have a problem. The aorta can become a little bit narrowed, and then that would change wherever that narrowing is. The pressure in the arm would be now much higher than the pressure in the patient's thigh. And so we know that there's what we call coarctation of the aorta occurring. If we get a thigh pressure that is a lot lower than the person's arm pressure, okay? Developmentally, normally when we're getting measurements on infants, we not only get the vital signs on infants, but we have other measurements as well. So for an infant, we may get the length. So we may have to measure them from head to toe, see how long that infant is. We do this for babies. And we also do get their head circumference as well and their chest circumference as well. So this baby's on a platform scale. That's one of the ways that we actually measure the infant. This is how we would get their head circumference and their chest circumference as well. And we measure those until probably they get to around age 2 or so, and then we really no longer measure the chest and head circumference, or sometimes do it annually. So for infants, when we're assessing vital signs, we want to do the same thing for vital signs. But the little ones are a little bit squirmy, and once you start becoming a little bit more invasive, then you're going to hear the screaming and crying. So we want to do these measurements, the ones that we don't really have to touch the infant too much for. And so, like if you have a sleeping baby, you don't really want to start with a temperature by putting it in the baby's ear, right? Because they're going to wake up. But you may want to assess their respirations to begin with, or maybe their pulse. So we start with those almost non-invasive things like respirations and pulse before we hit the temperature and the blood pressure, because those are going to change. Once the infants start crying, you're going to have a change in the respirations and the pulse. And now that will not be correct. But then you do the pulse, the temperature, and the blood pressure a little bit later. For the older adult, we may look at looking at the person's gait. What does that gait look like? Okay, as we get a little bit older, we may compensate for, say, arthritis or things occurring. The older adults also generally have a lower weight when they get a little bit older. Okay, they don't have as much muscle mass as they did before, and the fat generally has moved from, say, their face, their upper extremity, and sort of sits now around the abdomen or the hip area. And then they're not as tall as they used to be. You may have heard your grandparents complain that, oh, I shrunk. I'm not as tall as I was when I was a younger man, right? And so the body water is what actually decreases in the older age. And so think about the vertebral column, right? Those 33 areas of sort of toothpaste consistency in between the vertebral column, right? In between those discs. And so if they've actually lost body water, so the space in between the disc or the disc, it would lose the water within it. The person's vertebral column becomes a little bit shorter as well. So we lose bone structure as we age. Then there's also some flexion in the knees and the hips, which would actually bring the person a little bit closer to the ground. So, their knees and hips flex a little bit, and then you've got that shortening of the vertebral column. So that makes the person a little bit shorter. So indeed, they are shorter. But as we look at the person, it looks like their arms have grown long, right? But their arms haven't gotten any longer, because remember, our long bones stopped growing until about age 21 or so. So it's not that their arms have grown longer, it's that the vertebral column and the flexion of the hip and knees has occurred. So it looks like their extremity has grown. Some other changes occur in temperature as well because of the change. The older person may not be able to have a higher temperature, right? Their pulse may feel a little bit stiff, a little bit more rigid, maybe a little bit easier to palpate the older person's pulse because you can really get to it. Their respirations may be a little bit off as well. It may be a little bit less because the person is not able to open up their chest and take a big, wide breath. So their vital capacity has been decreased. So now we're going to have decreased reserve volume as well in the person's chest. And again, their vessels, the arteries, could have had, the cholesterol buildup, and of course, our arterial, not artery, has become stiff. Okay, so arterial sclerosis could occur, not the plaque buildup, and so it becomes a little bit stiff, and the vessels are a little bit difficult So the diastolic blood pressure increases a little bit, but the systolic blood pressure actually does not change. So for the older adult, we now have a wider pulse pressure. Okay, so respirations, again, when they're a little bit older, you have a decrease in vital capacity for the respirations. And their blood pressure has maybe changed. So again, a wider pulse pressure, and we remember what the pulse pressure meant, right? The difference between systolic and diastolic. Oxygen saturation is one of those other things that we could assess. Also, so we have to use an oximeter to assess it, and it gives us the percent value. As that light goes through, hit the blood vessels, it converts it to a percentage, and then we get the percentage when we actually read it. So anywhere from 97 to 98 is what a normal healthy person would be for SpO2 values. Sometimes a patient, you may see the doctor writing orders to keep the person's SpO2 level above 92%, etc. So we will follow those as well. We may have to administer oxygen therapy to the person if their SpO2 level is low. So on your left is an example of what a SpO2 monitor would be. Okay. And on the right, you have monitors that are actually connected to other machines, like the blood pressure machine. So it's on the older gentleman's finger, the SpO2 monitor, as the other vital signs are being completed. And what you are getting when you use a machine to check the person's vital sign, really, if you're palpating it, the palpable pulse should be what's reported on the machine itself. And when our patient gets a little bit sicker, the best way to actually assess the blood pressure is for you to take the patient's blood pressure. We can utilize a Doppler as well if we cannot assess a person's blood pressure. So we can use a Doppler for blood pressure measurement, and instead of where your stethoscope would be, we put the Doppler down, and the Doppler actually amplifies that sound. So once you inflate the cuff, it's almost as if you're taking a two-step blood pressure. Once you don't hear that pulse anymore beating, you want to go 30 above that, right? Above the oscillatory gap area. And so when you start deflating it, then you're going to hear the first beat that you hear from the Doppler would be the systolic blood pressure, and then the last beat would be the diastolic blood pressure. We may see this Doppler technique utilized in, say, someone who's very critical, maybe in a code situation where you cannot get the blood pressure on a patient. They may actually utilize a Doppler in this instance. So sample charting, if you're charting vital signs, we have a patient, 47-year-old black female, high school principal, well-nourished, well-developed, right, appears stated age. Patient is alert, oriented, cooperative, with no signs of acute distress. Height, 5'4" or 163 centimeters. Weight is 57 kilograms or 126 pounds. The temperature is 37 degrees Celsius. Pulse is 76. Respirations are 14. Blood pressure is 146/84 in the right arm, and it was sitting. So that would be just how a person would document objectively what that patient was in looking at those areas. And then we have some abnormal findings that you could actually note as well. So some abnormal findings related to the person's body height. You may see a person really, really tall, gigantism, or a person that is a dwarf, really, really short. Related to bone structure, you could have acromegaly occurring, and that would be the facial features changing, like a woman would look more manly, and that's because of hyperpituitarism that has occurred. You may see what the body position or the body structure looks like a person who has a problem with what they look like, and so they stop eating a lot and not recognizing that they're losing body fat and the body mass from muscle. So a person who has anorexia nervosa, or you may actually see Marfan syndrome, This would be a change in the person's sort of bone structure height-wise. If you look at their wingspan, it will be much longer than, and that's from fingertip to fingertip, arm extended, what a normal person generally would look like. And then for changes in blood pressure, you have hypotension and then hypertension. So we take that 120/80 value, anything lower than that would be considered hypotension, and anything higher than that value would be considered hypertension. And your book has a caption as to what the normal blood pressure values are, as well as normal heart rate values. All these are in your book. And this is just a caption of a person that has Cushing's disease and some of those things that you actually see with the patient. So this is a great slide. I'm not going to spend a whole lot of time on this slide. You can actually take a look at those things. It would come in handy, especially once you start going to your other classes like fundamentals and moving into med-surg class for a person that has Cushing's disease. And this is related to pituitary disorder. So your nurse is assessing a patient with a heart rate of 55. Which of the following patients would be most likely to have a pulse rate of 55? Would it be a 70-year-old telephone salesman who's dehydrated, a 20-year-old runner who had surgery 4 days ago for a fractured leg, a 67-year-old with an exacerbation of COPD, or an infant who has a temp of 100.1? So who would have a heart rate of 55? Is it the infant? No, it cannot be the infant because their heart rate is a little bit higher. How about the 67-year-old with exacerbation of COPD? Absolutely not. In this instance, that heart rate would be much higher. Patient would be tachycardic. How about the 70-year-old salesman who's dehydrated? Nope, because here the person has lost volume, right? So more viscous blood. Are we going to get a higher heart rate or lower? Higher. We're going to get a higher. So that wouldn't be the patient. The answer is a 20-year-old runner, surgery 4 days ago for a fractured leg, because this 20-year-old runner probably have a well-developed heart that is very efficient, so their heart rate could be lower. Any questions? We will pick this up in the question and answer session. Thank you.